Welcome to The Explainer. Today, we're stepping straight into a high-stakes clinical courtroom. We are conducting a rigorous audit of pulmonary failures, where our absolute main goal is to separate true physiological signal from mere noise. We're going to look closely at the data, the diagnostics, and the literal physical architecture of the lungs to find out exactly what goes wrong when the respiratory system tips out of balance.
So you're faced with the ultimate diagnostic question you're going to see time and time again. Why are your patient's oxygen levels dropping? And what is the true physiological culprit? It is just incredibly easy to get distracted by a flashy symptom and jump to the wrong conclusion. Today, we're building a systematic breakdown to make sure you never make those diagnostic leaps in the dark.
Here's our clinical docket for today's explainer. First, the AA gradient audit. Second, sleep obstruction physics. Third, the restrictive barrier. And we'll wrap it all up with the final verdict.
Let's dive right into Section 1, the AA gradient audit and establishing the baseline. Okay, before we start diagnosing complex diseases, we need a literal lie detector test for the lungs. Enter the AA gradient. That's the alveolar oxygen minus the arterial oxygen, or big A minus little a. This is your most crucial executional pearl. If your patient is hypoxemic, but their gradient is totally normal, while the lung architecture itself is completely fine, the air just isn't getting into the alveoli. We see this with hypoventilation from things like an opiate overdose or just being at a high altitude. But if that gradient is elevated, it demands an anatomical audit. It means the lung is actively failing to transfer oxygen properly, usually due to a VQ mismatch like a pulmonary embolism, a shunt, or some kind of diffusion defect.
Moving right along to Section 2, sleep obstruction physics and the 50-50 dilemma.
Picture this: an obese patient comes in with severe daytime sleepiness. Your first instinct is probably to just order a sleep study, right? But hold on, we need a strict audit of their ventilatory drive to separate two very different conditions. On one side, we've got obstructive sleep apnea, or OSA. This is all about transient airway collapse while they sleep. Crucially though, these patients have a perfectly normal daytime PaCO2 and a normal pH when they're awake. On the other side, we have obesity hypoventilation syndrome, or OHS. With OHS, the central ventilatory drive or chest wall mechanics are actually failing. So what's the defining tipping point? It's chronic daytime hypercapnia. We're talking an awake PaCO2 greater than 45, often paired with a compensatory metabolic alkalosis as the body's bicarbonate buffer kicks into high gear.
In our clinical courtroom, you really have to filter out the noise. Snoring, a large neck circumference, honestly, that's just noise. You're going to see those in both conditions. What you really want are the true signals of chronic hypoxemia in OHS. Think about it. The kidneys respond to chronic low oxygen by overproducing red blood cells, which leads to polycythemia with elevated hemoglobin and hematocrit. Furthermore, the right ventricle is constantly struggling against hypoxic pulmonary vasoconstriction. This leads straight to right heart failure or cor pulmonale, which often presents physically as a remarkably loud P2 heart sound.
And this brings us to a massive and, quite frankly, dumb mistake in management: trying to treat pure OHS hypoventilation with CPAP alone. It's a real trap. While a continuous positive airway pressure machine is fantastic for fixing the obstructive airway component of OSA, it totally fails our OHS patients. Why? Because they are failing to ventilate. They absolutely require bilevel positive airway pressure, or BiPAP, to physically provide the ventilation needed to blow off and clear that chronic toxic carbon dioxide burden.
Next up, Section 3, the restrictive barrier. We're looking at interstitial compliance versus granulomatous nodes.
Now we're shifting our focus down from the upper airways and deep into the parenchyma of the lung itself. Let's compare the stiff, heavily scarred lung of idiopathic pulmonary fibrosis with the systemically inflamed lung of sarcoidosis. The real tipping point between these two lies in the nodal architecture and the DLCO. IPF typically hits older patients. You'll hear those classic, coarse, Velcro-like crackles on inspiration, and their DLCO will be significantly reduced because that alveolar capillary membrane is permanently scarred. Sarcoidosis, on the other hand, usually strikes younger patients. It's a systemic disease featuring non-caseating granulomas and bilateral hyaluroadenopathy. It also loves to cause extrapulmonary issues, things like uveitis, erythema nodosum, or even Bell's palsy. And early on in sarcoidosis, their DLCO could actually be completely normal, depending on how much of the lung tissue is actually involved. Just take a look here. This brilliantly illustrates the sheer physical destruction caused by idiopathic pulmonary fibrosis. See those clustered cystic air spaces on the periphery of the CT scan? That's the classic honeycombing pattern, and it tells you there is severe, irreversible scarring. Then, when you look at the biopsy tissue, you get this highly heterogeneous patchwork appearance. It's interstitial fibrosis that's just heavily laden with collagen, basically obliterating the lung's delicate gas exchange architecture.
Now, in stark contrast, sarcoidosis builds a totally different radiographic story. We use the scatting chest X-ray staging for this, which runs from stage 0, meaning a totally normal chest X-ray, all the way up to stage 4, which is advanced pulmonary fibrosis. But the absolute classic presentation, the one you must burn into your memory, is stage 1, isolated bilateral hilar adenopathy. Seeing those enlarged lymph nodes right near the center of the chest is basically a giant flashing neon sign for systemic sarcoidosis.
But wait, here's another glaring mistake we often see in the clinical courtroom: aggressively treating an asymptomatic patient who happens to have stage 1 sarcoidosis. Look, unlike IPF, which is relentless, progressive, and lethal, sarcoidosis is a completely different beast. A ton of early stage 1 sarcoidosis cases actually resolve completely on their own, completely spontaneously. You absolutely do not execute treatment with systemic corticosteroids unless that patient is genuinely symptomatic, meaning they have severe lung dysfunction, hypercalcemia, or dangerous cardiac, ocular, or neurologic involvement. Otherwise, just watch and wait.
Finally, we arrive at Section 4, the final verdict, where we tie it all together. We've audited the baseline gradient, analyzed sleep obstruction, and investigated restrictive barriers. So I want to leave you with this provocative final thought, bringing us right back full circle to our foundational rule. Imagine a patient is sitting right in front of you with a dangerously low PaO2, but you calculate their AA gradient and it is completely normal. What's the true physiological failure? The answer? They just aren't breathing. The lung architecture itself is entirely innocent. So please, do not blindly search for a pulmonary embolism or just reflexively prescribe an inhaler. You need to search for CNS depression, an opiate overdose, or severe chest wall restriction. Remember, in this clinical courtroom, the gradient never lies. Thanks for joining me on this explainer, and keep auditing those physiological signals.